Let me ask you something. What if the most complex organ in the human body, the one that defines who we are, our thoughts, our memories, our identity, suddenly loses control of itself? Not gradually, not predictably, but in a sudden electrical storm that unfolds within seconds. That moment is what we call a seizure. But here's the paradox. While seizures are dramatic, visible, and often frightening, the real mystery lies in understanding what the brain is actually going through in that moment. Good morning, everyone. On behalf of SGRD Sign, I, its President Kanishka Verma, welcome you all to this international webinar session, Brain in Crisis, the Biology of Seizures. Today, we are not just here to learn about seizures. We are here to understand the brain when it is at its most vulnerable. And to guide us through this journey, we are truly privileged to have with us an exceptional clinician, educator, and a mentor. It is my honor to introduce Dr. Rebecca Kate Miller-Kuhlman, Clinical Associate Professor in Neurology and Neurological Sciences at Stanford University. Dr. Rebecca is board certified in neurology as well as electrodiagnostic medicine, and her clinical expertise spans a wide spectrum from epilepsy and neuroimmunology to neuromuscular disorders and cognitive conditions. Her approach reflects not just depth but a remarkable breadth of neurological understanding. She completed her medical training at UCSF and went to pursue her residency and fellowship at Stanford University, where she continues to play a pivotal role in shaping medical education. Academically, she serves as the Assistant Dean for Pre-Clerkship Education and directs the Science of Medicine course, influencing the foundational learning of future physicians. Her excellence in teaching has been recognized with multiple prestigious honors, including the Outstanding Lecture Award and the Henry J. Kaiser Award for Excellence in Preclinical Teaching at Stanford. What truly sets her apart, however, is her passion for teaching and her ability to transform complex neurology into structured, intuitive, clinical reasoning. I had the privilege of attending her session on red flag versus red herring, the art of diagnosing stroke and its mimics, where her approach, breaking down stroke into domains like facial weakness, vision changes, and dizziness, was incredibly insightful. Her emphasis on key diagnostic principles, such as the importance of abrupt onset and detailed history taking, left a lasting impact. And what made the session even more engaging was how she involved all of us, encouraging active thinking through case-based discussions. Today, she will be taking us through a case-based overview of seizures, helping us not only understand the science, but also think like clinicians. Ma'am, it is an absolute honor to have you with us today.
Oh, wonderful. Thank you so much.
Thank you, ma'am.
It's certainly a pleasure to be here. And I'm so impressed that you're all logging in to learn extra neurology on a Sunday morning. That's also, a really it's something that you should all be proud of in terms of how you choose to spend your time.
Thank
Let
you,
me
ma'am.
reshare. Let
Yeah,
me reshare my screen
sure.
and we
And
will dive right into it. Go ahead.
yeah, and also, before we begin the session, I would like to take a moment to acknowledge the pillars behind this initiative. We are deeply honored to have with us Dr. Saiba Kukreja, Dean Undergraduate, Professor and Head of Department of Biochemistry, and Dr. Neha Uppal, Professor Department of Biochemistry from Sri Guru Ramdas Institute of Medical Sciences and Research. Their unwavering support towards student-led academic initiatives has been the driving force behind the establishment and growth of our chapter. It is because of their vision, encouragement, and belief in us that today we can proudly say that our institution is home to the first signed chapter in the state of Punjab and among the very few active chapters in whole of India. And it is truly because of their support that today we are not just hosting a session, we are hosting a platform that connects globally. From welcoming participants across India to proudly having attendees joining us today from Turkey, Colombia, Malaysia, and United States. This moment reflects the impact of the foundation they helped build. We extend our deepest gratitude to their constant mentorship and support. Thank you so much for joining, ma'am.
Thank you, Dr. Rebecca, for consenting to give a talk on a very important topic and also encouraging our students at SGRD. Thank you so much.
Absolutely, it's my pleasure.
Yeah, thank you.
And before we begin with the session, to give our attendees a brief insight onto our chapter, our journey so far, and the academic initiatives that we've undertaken, I would now like to invite the Vice President of SGRD Science Chapter, Harnoor Kaur, to take us over and share more about our work and vision.
Thank you, Kanishka. Good morning, respected guests, esteemed faculty, and fellow students. I am Harnoor Kaur, Vice President of the SGRD Science Chapter, and it is my privilege to welcome you all to today's webinar. The SGRD Science Chapter, as part of the Student Interest Group in Neurology, is dedicated to fostering a deeper interest in neurology and neuroscience among medical students. We take pride in providing a platform for students to engage with the global academic community. As a chapter, we have been consistently working to promote neurological awareness and education. One of the ways we engage with our audience is through our social media platforms, where we share posts twice or thrice a week that simplify complex neurological concepts, keeping our community informed and inspired. In addition, we actively participate in initiatives such as we started our journal club in November last year. November being the Epilepsy Awareness Month, we made sure that our journal club delivers a session on recent advances on epilepsy. The collaboration was conducted in collaboration with ESIC Sign. Previously, we had the honor of organizing an insightful session with Dr. Archit Balor, an eminent personality known worldwide for his work in field of medicine, which was greatly appreciated by both students and faculty alike. Building on such initiatives, we also create short educational videos on seizures, where we shared on our YouTube channel to make important neurological information accessible, understandable, and impactful for a wider audience. We are truly honored to have Dr. Rebecca with us today, who will be delivering a session on the biology of seizures. She is a clinical associate professor of neurology and neurological sciences at Stanford University. Dr. Rebecca is a board certified neurologist with expertise in epilepsy, cognitive, and neuromuscular disorders, and is widely appreciated for her dedication to medical education and mentorship. I would also like to extend a warm welcome to our distinguished dignitaries, Dr. Sahiba Kukreja, Dean Undergraduate, Shri Guru Ramdas Institute of Medical Sciences and Research, and Professor Dr. Neha Uppal, Professor Biochemistry, whose presence adds immense value to this event. We are grateful to the American Academy of Neurology for their continued support of initiatives such as SIGN. I am confident that today's session will be an enriching and insightful experience for all of us. Thank you, and I look forward to the engaging discussions that lie ahead.
I thank you, Harnoor. I now invite Dr. Rebecca to take over the session.
Wonderful. Let me share my slides. All right. So a couple things as we jump into talking about seizures today. I will ask you occasionally to either give answers or to unmute. If you're going to take the time to attend the lecture on the weekend, definitely expect to be thinking critically and actively while we do this. If you don't feel comfortable, not a big deal, but when you have a second, please put in the chat what year you are. I understand we have a mix of different years of students. It's just helpful for me to titrate. And while you're doing that, note that if you're in your first or second years of training, some of this will be more new to you. If you're later on, some of it will be review, but we'll hopefully get into some of the more nuance. My hope is that there will be something for all of you, whether it's review and really firming up concepts, or if it's something entirely new. Here's our agenda for today. So by the end of this, we will be going through cases throughout, and some of the specific cases not in order are listed on the right-hand side of this slide. But my goal is for you to also have a systematic way of thinking about seizures and their mimics as we go through and as you begin to see these patients more and more in your clinics. So let's start out by some of the just basic terminology that, again, many of you have heard before, and define what seizures are. So I want you to think to yourself about what you know about seizures. Take a second and think about it. And I also want you to think and make sure that you feel very clear for yourself about the difference between seizures and epilepsy. So you can see on this slide right now up, I have a definition of what seizures are, right? We have, it's a transient neurologic event. When we think about transient episodic neurologic events, typically are brief, sometimes we're talking about TIAs or mini strokes, sometimes we're talking about migraines, and sometimes we're talking about seizures, just in terms of very brief things. In this case, seizures, as many of you know, we'll talk more about the pathophys in a minute, are due to abnormal or excessive synchronous neuronal activity in the brain. Our neurons are meant to fire in many different patterns, but they are not meant to fire all in synchrony. And when you have too much synchrony, it can lead to what I think of as an electrical storm, which is a seizure. Now, take a second and again, challenge yourself. The difference between seizure and epilepsy, right? A seizure is simply a single event. A propensity towards repeated seizures is what ends up labeling someone as having epilepsy. The specifics of the epilepsy label are either having two seizures at least 24 hours apart, because if you have one provoked seizure, you're more likely to have another one in short order. Or one unprovoked seizure plus a very high recurrence risk for seizures. So something structural in your brain or in your history that makes us think that seizures are very likely to reoccur might earn you a diagnosis of epilepsy, versus seizures that are a recognized part of an epilepsy syndrome. So as we go through cases, I want you to, again, I'll give you a little bit of time. We'll sit here in silence together. And my hope is that you're all at your own individual computers thinking. And for each of these cases, this is the approach I want you to take. I want you to think about how they start. I want you to look for any provoking factors. And if you're not sure what those are, we'll get into it. And then I want you to work on characterizing the event. For seizures, we call it seizure semiology. What type of episode is happening? Describe what's going on with the patient and make sure that you have words for yourself. And then we're going to think through the etiology of what's going on. At any point, I want you to ask questions. You may either unmute. Please use the chat liberally and type any questions that come to your mind, and I will be happy to answer them as we go through. And we'll also have some time at the end. All right. So, pathophysiology of seizures. Now, seizures and epilepsy, of course, are you can spend years studying them. And so what we're going to cover in the next 20 slides or so is some things are a little bit simplified, but the basics are we have an imbalance with too much excitation and not enough inhibition in the brain. So again, you can think of it as, typically you've got neurons firing in an excitatory way and an inhibitory way, and all of these different pathways and circuits. If something tips our brain towards too much excitement, our neurons are a little bit more likely to fire, and they're a little bit more likely to fire together in a pattern that can then become self-reinforcing. And that self-reinforcing pattern can then spread and cause all of the symptoms that we associate with seizures. Now, so many of you have probably heard the term seizure threshold. So every one of you, every one of us, and every one of our patients has a seizure threshold. So healthy people can absolutely have seizures. People who do not have epilepsy, if enough things happen to lower their seizure threshold. So certain medications can lower the seizure threshold. One that we use a lot in my practice is Wellbutrin. Like some of the antidepressants can lower our seizure threshold. Sleep deprivation causes more excitement in our brain and causes issues with our GABA. Being febrile, other metabolic derangements, alcohol, especially alcohol withdrawal. And then, of course, if there's anything in our brain that is causing irritation or inflammation, so that can be a brewing cancer in our brain. It can be an old stroke. It can be something developmental. Sometimes children have little things called cortical dysplasias where a little bit of the cortex develops a bit funny. Any of those things can lower that threshold and make seizures more likely to happen. If that threshold is lowered enough and there are repetitive seizures, that's what usually begets a diagnosis of epilepsy. Any questions so far? I'll just assume you're all with me if you're quiet. Wonderful. So this is the seizure classification from the International League Against Epilepsy, which was a pretty big update back in 2017. So it's been around now for almost a decade. Before this, we talked about things like simple partial and complex partial seizures. So with this classification scheme, we entirely, hold on just one second. Sorry, it's a recently bedtime here in California. That's just my 10-year-old son coming to check on what was going on. Okay, let me make sure that I know where I was talking. Yeah, so the International League Against Epilepsy classification of seizures. So we moved away from older terminology like simple partial and complex partial. And now let's just walk through this diagram on the left. So when you see a seizure, it's either focal in onset or generalized in onset. You'll notice I put in italics that we classify it based on where the seizure starts, not where it ends up. So a focal onset seizure means it's starting in one part of the brain. Often they start with much more localized symptoms. It can be shaking in one limb. It can be tingling that crawls in what's called a Jacksonian march, where it crawls up an arm in the pattern of the dermatomes, but in your brain. It can be a rising sensation or a sense of impending doom, which we get when it starts sometimes in some of the temporal and limbic regions. Within this focal onset, there can be focal aware or focal impaired aware seizures. And this is fairly self-explanatory, right? Focal aware is this, the person can be sitting there with their arms shaking and they can talk to you throughout it. They're totally with it. It's not affecting their cognition or their consciousness. Whereas impaired awareness sometimes presents as something more focal, but there's a staring spell, there's confusion with it, there's something that's altering consciousness. Now, focal seizures can have secondary generalization and become what's called a bilateral tonic-clonic seizure with shaking of the whole body. Now, generalized onset is very interesting. So this comes from, if you are getting really deep into brain physiology, right? We think of brains increasingly not as a lot of different points in the brain, but as all of the circuits, right? All of the ways that the different parts of our brains are connected and interfeeding between each other. And especially some of the circuits that connect our cortex to our thalamus are very bilateral. And if it's within some of these very bilateral, more diffuse circuits that the seizure starts, then it actually starts generalized. A generalized seizure, anything that affects both cortexes at the same time, results in pretty immediate loss of consciousness. And the most typical thing we see with that is a bilateral tonic-clonic seizure. So tonic means muscle tone, tense muscle tone. Clonic means shaking. Myoclonic seizures are again referring to a slightly different type of shaking. And then atonic seizures are when people have drop attacks and they lose all muscle tone suddenly. Non-motor generalized onset seizures, absence seizures, are a specific case that we'll cover in a little bit more detail. So this is, this is the way, again, as we go through cases, I want you to think of, first of all, is this a seizure, right? And then I want you to think about, what type and where are we at? With that, we're going to go into it. All of the cases I'm going to give you today, I'm going to give you in pairs. So we'll start. You can go ahead and take a second and read case A to yourself. I will also read it out loud, but feel free to get ahead of me. So both of these are 28-year-old women. The first one, case A, says brought in by family after a witnessed episode. So they were out kind of minding their business, and out of nowhere, when she was walking, she suddenly stiffened and then fell with rhythmic jerking of all limbs. And it lasted, they think, about 2 minutes. I will tell you to families that when a family member does this, they often can't tell you exactly how long because it's so concerning that it can feel like forever, even if it's only a couple seconds. When the shaking stopped, she was confused. She did not remember what had happened, and she was kind of sleepy. There was one similar episode 6 months ago. This is the first time the patient is presenting to care. In case B, we have a 28-year-old woman again who was at a crowded bus stop. It was a hot day, and she had been standing in the heat waiting for the bus for about a half hour when there was a collapse with shaking that lasted about 1 minute. After a brief loss of consciousness, there was a rapid return to normal within a few seconds. The woman notes that she did have some prodrome of feeling kind of a lightheaded feeling and her vision sparking and going dark before the event. So take a second to yourself. I'll give you about 10 seconds. I want you to put your money down about, just challenge yourself. No one else is going to know about what you think each of these events are. You can give me a thumbs up when you feel like you've got it. You guys, do you all have the same little like symbols on your Zoom? Yeah, perfect. Thanks, Meta. Okay. So going through this, so case A is one of our seizures, right? So in terms of considering how this patient presents, in terms of where they're provoking factors, there was nothing described, right? There was out of nowhere generalized shaking. And it seemed like it was generalized from the start. So we're assuming this is probably a classic GTC or generalized tonic-clonic seizure. The other things that are clues in this case, tongue bite on the side of the tongue. The patients often bite their own tongue during the shaking when they have generalized seizures. And that's actually a fairly specific sign for seizure, especially when it's on the side. And then the postictal state, that confusion afterwards, right, is a sign that there was this abnormal electrical storm in the brain. This patient, since they have had 2 unprovoked events, likely meets diagnostic criteria for epilepsy. Case 2 is interesting, and I bet some of you in your clinical years have seen this. Very often, when people syncopize, when they lose consciousness from things like heat or prolonged standing, normal loss of consciousness episode, non-epileptic, it often gets mistaken for epilepsy because there is myoclonus when people pass out. So as they pass out, they have some jerking. It's usually much briefer. And the biggest difference, right, is when we pass out, it's because our brain is not getting enough oxygen and our body says, hey, I need your head to be at the same level as your heart so I can pump more oxygen to your head. As soon as you get sideways when you're syncopizing because you need more blood flow, that restores the blood flow, your consciousness comes back. There's not been an electrical storm in your brain. You go right back to where you were. So that lack of a post-ictal state is really helpful. But this is such a common consult. If you at all go into neurology, you do a lot of seizure versus syncope consults. So you are all ready for it. So again, just reiterating some of the key clinical approaches to seizures. Whenever someone is coming in, if they have had a loss of consciousness event, you have to get collateral history from someone else, if at all possible, who can explain what happened before, during, and after the event, in addition to taking a good history from the patient. Picking the patient themselves, figuring out what the last thing they remember before the event and the first thing they remember after can be very helpful. Characterizing the event, as we talked about, in terms of its onset, how long it lasted, semiology, what was going on. There was shaking, it was focal, it was everywhere, what other symptoms? And then again, looking out for that postictal state. In this case, we're also, in terms of associated symptoms, would mention that lateral tongue bite. And then considering the differential, and we'll go a bit more into mimics as well. We're all still with me? Wonderful. Okay. And then we'll talk about workup a bit more. So we're going to jump into a next pair of cases. So these are both cases of an 8-year-old girl in school. So case C, and again, read these along with me, and I want you to challenge yourself to, if you were presenting this to an attending, you were on the wards, of just describe what's happening with this patient and try to start classifying them in your brain as we talk about it. So case C, the parents are concerned about these staring spells. The teacher collateral mentions that they happen multiple times a day, especially when they're doing homework. And the teacher can interrupt the staring spell by calling out the students' names. Versus in case D, again, it's a teacher noting zoning out multiple times per day. In this case, it's really, she's specific that it's always about 10 to 20 seconds, and it's staring blankly, and there's some eyelid fluttering, and the student, if they're talking, will actually stop in mid-sentence. And then 10 to 20 seconds later, they go right, they resume their sentence, they go right back into what they were doing. So there, you'll notice no like post-ictal here, but academic performance is declining from these episodes. Some of you more in your clinical years, you might be able to put a finer point on what these cases are. If you're earlier, I want you to be thinking, is this seizure versus not seizure? Okay, I see a couple thumbs. Okay, so let's talk about these. Excellent. So yes. So these are this is a very good description of an absence seizure, exactly right. So absence epilepsy is its own thing. The seizures from patients with absence epilepsy are always brief, usually under 30 seconds. The biggest thing is they can't be interrupted. What you ask the person in the moment is, if I snap my fingers in your face, do you blink? Do you react, right? There can often be these automatisms. So automatisms are things like lip smacking or the eyelid fluttering that was described here. And then there is a characteristic EEG pattern. So when you do an EEG and you actually look at the brain waves, this is also like a favorite question on everyone's boards, is the 3 hertz. So 3 times a second, there's a spike in wave. So this type of epilepsy tends to present in children under the age of 10. It peaks around 3 to 8. And the seizures are actually usually very, very frequent. So they're brief, they're frequent. And because there's not a big postictal state from this, they sometimes go unrecognized for a while and get confused with just kind of being inattentive. The nice thing about absence epilepsy is the vast majority of it resolves before adulthood. If you're in your clinical years, you might know there's a specific medicine we tend to use for absence epilepsy that we don't actually use in a lot of other type of epilepsies. If you know what that is, you can put it in the chat and I'll tell you in a minute otherwise. Now, compared to our other child who, while homework was kind of zoning out, no automatisms, probably it was just having daydreaming or inattention. Now, of course, if there's a lot of inattention, they might need evaluation for attention deficit disorder. Sometimes with these staring spells, it can be hard to truly know if you can't get a great history until you do an EEG, but EEGs aren't also always available. And so a really good clinical history and really teaching the people around them to test and see what's going on can be very helpful. The other interesting clinical tidbit about absence seizures is you can provoke them by hyperventilation. So when the patient breathes fast for absence epilepsy, and you breathe off your carbon dioxide, it's kind of interesting, like that hypocapnia causes cerebral vasoconstriction, and that can trigger the increased neuronal synchrony, all of those neurons firing together, and actually cause the absence seizures. And the treatment we use most commonly, at least in the United States, is ethosuximide for absence epilepsy. So it's a little bit specific. It works very well. And so this is just reviewing those cases and the difference between daydreaming and absence epilepsy. Yep, you got it. Perfect. All right, one more pair of cases, and then we'll pause and talk a little bit more about organizing. So just to remind you where we've been so far, we talked about seizures versus epilepsy. We talked about seizure types and why seizures happen. And now we're doing some case examples of seizures versus mimics before we go into a little bit more detail about seizures themselves. All right. So again, let's continue our same approach towards these cases. We've got a 22-year-old woman in case E and case F. So on the left-hand side, you see jerking of right arm and face, lasting 45 seconds, followed by confusion. This has happened 3 times in 2 months, and it's always the same pattern. The patient recently started having new headaches. There's no loss of consciousness. Versus case F, where we have bilateral arm and leg shaking, lasting 5 to 15 minutes. And during this time, the patient has their eyes closed, there's arching of the back, and there's these side-to-side head movements, okay? Events tend to occur when the patient has high stress and normal neurologic exam between the events. I want you to take a second and put your money down on classifying these. Give me a thumbs up when you're there. Give you a couple seconds to think about this one. Okay. I see some thumbs ups. So let's talk through these. So these were getting more difficult, and that's with intention. So let's first take Casey. So this is a focal motor seizure. It's focal because it's just the right arm and face, right? So it's not generalized. The focality of it tells you where it starts. So you know that we're in the left hemisphere if it's the right arm and face, and you know that you're in the back of the motor cortex, right? The back of the frontal lobe where the motor cortex is. The other clinical note here is anytime there's seizures and new headaches, that's sometimes concerning for something like a new mass lesion. It could be an infection or inflammation or something neoplastic. So this patient definitely needs head imaging as a priority. So focal seizures, I will send these slides to you, Kanishka, when we're done, in case anyone would like them. And you could make this table a lot longer, but I prefer to give you a couple things to remember than very long lists. So as a starting place, just remember that what happens tells you what lobe is probably involved when the focal seizure starts, right? So it should make sense to you. Motor is the back of the frontal lobe where you've got your somatomotor cortex, whereas you can have seizures that are sensory only. How do you differentiate that from just having a tingly numb arm? It's that thing called a Jacksonian march, where it's actually marching up the dermatomes. It's marching up the somatosensory cortex. So it often will do something like it'll actually spread from the face to the arm and maybe up to the leg. So the way a seizure, one of my professors when I was training always described seizures like a song or a symphony. They actually have a beginning, a middle, and an end, and they evolve. So you can think about that. Seizures can start with unusual visual phenomena, and that would be likely from the occipital lobe, which probably doesn't surprise anyone. And then again, the emotional things, it can be fear, it can be déjà vu. Some people describe a sense of impending doom. And that typically is from your mesial temporal lobe or some of your limbic areas. And same thing, the automatisms tend to also be temporal in onset. And again, so that Jacksonian march, that can describe both the sensory or the motor. So the motor can also march up the cortex. So that again tells you. So this I could actually update to say frontal or parietal, but that motor or sensory march is something that just really tells you that it's likely a seizure. So again, here we have a focal motor seizure. Here is really interesting, case F. This is one of the harder things, I think, especially when you're a medical student. So when patients have seizures and they have generalized seizures, the movements are never this way. It's interesting. And they're never bicycling of the legs. That's actually a bilateral, very coordinated movement. It's usually kind of just stiff shaking and arching of the back. The other thing when people have generalized seizures is their eyes will be open. Having closed eyes during a seizure is a very strong sign that it is not an epileptic event. It is not an electrical storm in the body. It is a different kind of spell. So this is actually giving you an example of what are called, psychological non-epileptic spells, which are part of functional neurologic disorders. So there's a bunch that I want to say about this, because functional neurologic disorders sometimes get viewed as the patient faking or being dramatic. And quite frankly, we know that it's really not that. There's other ways that the patient's circuits are working in an aberrant way. The other thing that's really tricky is a lot of people with epilepsy also have non-epileptic events. So one non-epileptic event does not mean the person doesn't actually have seizures or epilepsy. So going into PNAS for a second, this is a seizure mimic that, again, it's the shaking episodes that are due to a functional neurologic disorder. This represents up to a fifth of patients. I would say that's pretty accurate in what we see at Stanford. And these patients can get diagnosed with seizures or epilepsy. And very often it takes a while to really kind of piece this apart. And again, of patients who have PNAS, 10% actually have epilepsy. And of patients with epilepsy, it's a higher percentage when you look at it that way that have PNAS as well. So when you are talking to someone with this, the way you talk about it matters. This is not a diagnosis of exclusion. You actually don't say that, here's all the reasons it's not seizure. You don't do that. You say you have functional neurologic disorder, and here's all the reasons you have functional neurologic disorder. You make it a positive diagnosis, not a negative one. You explain that you agree how scary this is. You validate their experience. And then you talk to them about the fact that this is more of a software than a hardware issue. And what they need is to rewire their software circuitry, which is the realm of our psychiatry colleagues and cognitive behavioral therapy. This can still be very disruptive, cause a lot of disruption in people's lives. And it takes a lot of collaboration to manage these patients well. Definitely, if patients like this who are truly PNAS come to you, you take them off of unnecessary seizure meds if you're sure that there aren't also comorbid seizures. The gold standard for this, when you can, is getting the patient hooked up to an EEG long enough so that they have their events on the EEG so that you can correlate that there's not an electrographic correlate of their spell. All right, I'm watching our time. I don't want to keep you too long on your Sunday morning. So this is a larger differential that you can dig into by yourselves a little bit for all of the things that can mimic seizure. So for example, we talked about the top two movement disorders. Not everything that shakes is seizure, right? There are many other types of tremors and unusual movements that patients can have that don't have this episodic stereotyped semiology. So the two things that I think are very helpful in thinking about mimics, the episodic nature is helpful. The fact that it's stereotyped most of the time, with some exceptions, because there's always exceptions to the rule, but most of the time seizures happen the same way every time. Some might be smaller and some might be bigger, but they're variations on the same thing. It's not a lot of different themes. We talked about daydreaming. Sometimes kids hold their breath. They have breath holding spells that can also look like either staring spells or convulsive spells, or syncopal spells. Sleep disorders, migraines can have all sorts of interesting sensory things with them. TIAs, right, can be episodic. And then, of course, other metabolic and infectious things can sometimes mimic seizures. Like when people are rigering from a fever, they can have generalized shaking, but they're going to be totally with it. If someone is talking to you while both sides of their body are shaking, it is not a seizure. If it is bilateral shaking from a seizure, they will be unconscious, because you can't have a bilateral electrical storm in the brain and have consciousness maintained. All right. We all still good? Covering a lot of ground in a short time here. This is another one of my favorite tables, which is going through things that favor whether it's a seizure or whether it's something else. So some of the things that I learned, I think, most quickly in residency for neurology, one is the eye thing. Again, eyes will be open during a seizure. Even if it's generalized and the patient is unconscious, they are unconscious with their eyes open. Very often they'll be deviated to one side, just like in a stroke. Like typically a seizure with if there's a lot of extra electrical activity, it pushes the eyes away. So you look away from your seizure and you look towards your stroke in terms of your frontal eye fields. And then closed, that makes you think that this might be a psychiatric non-epileptic event. Skin color, someone who is sweaty and has pallor, that's more likely to be syncopal, whereas someone who has a generalized seizure can actually truly get cyanotic due to the lack of blood flow. Mimics, I mean, so the triggers here, in standing or heat, that's making you think of syncope. Pain and stress might make you think of more psychiatric events. Seizures themselves are often unprovoked, or you can find those provoking factors that lowers the seizure threshold, like sleep deprivation. Stress can also certainly lower your seizure threshold. And like I mentioned, alcohol use, especially its withdrawal. And then, of course, that prolonged post-ictal state, when there is confusion after the event, that really favors seizure. Now, we talked about Absence epilepsy, which has no post-ictal state, so not everything does. So you really have to kind of look at all of the data in terms of figuring out what makes the most sense for the patient. No one of these things is going to make or break the diagnosis. The only other point here, I think, is the tongue bite. So it's often lateral when it's a seizure. And sometimes when it's psychiatric, people will bite the tip of their tongue. That actually doesn't happen in seizures. Like the tongue gets, because it falls to the back of your mouth when you're arching your back in a true bilateral seizure, it tends to be a lateral tongue bite. The tip of the tongue doesn't get bitten. So like where the tongue bite happens, if it happens, matters. Not everyone bites their tongue when they seize, of course. Okay. We're rolling right through it. This is potentially our last pair of cases before we talk about a couple other scenarios. So I call this the seizure spectrum. So these are both seizures, but I want you, especially if you're further along in clinic, to think if you know what type they are. And if you aren't that far along, I want you to just kind of think about the semiology and what tells you these are a seizure, okay? So 2-year-old boy, on the left-hand side, generalized shaking 2 minutes. This is in the setting of being febrile with a runny nose and a cough. Now, after the shaking in 2 minutes, the child was back to normal and playing within about 10 minutes. Now, on the right-hand side is same different 2-year-old boy coming to the ER in generalized seizure that's been going on for 15 minutes. And this is a patient with known epilepsy whose parents ran out of medicine 3 weeks ago. Still seizing on arrival and non-responsive. I see some good thoughts in the chat. Wonderful. So case G, we're going to really go from the benign to the severe here, which even if you are totally new to seizures won't surprise you, right? So case G exactly, sorry, case F. What is it? No, G. We're on G. It's getting late here. So case G is a febrile seizure, right? Which or a febrile convulsion, however you want to put it. So febrile seizures are the most common cause of seizures in children, and they are largely benign. There is a subset of people in whom who will eventually develop epilepsy who will also have febrile seizures, but up to 5% of children can have a febrile seizure before age 5 is the most typical. They are triggered by a fever. It does not have to be meningitis or encephalitis. Just any normal fever will do. Fevers lower your seizure threshold in general. Other things about this, they can run in families. So there can be a positive family history of febrile seizures. The higher the temperature and the longer it's been going on, like the more likelihood of this happening. In most patients, this is benign. They do not need to be medicated. They might, again, have a seizure with future febrile illnesses. In a subset of patients, if there's some complexity or something unusual about the seizure, it could be someone who is going to develop epilepsy and hasn't yet, who is kind of manifesting early from the fever. So we never say never, but in the vast majority of these, this is a very benign condition. It's very scary to parents. We say it's benign because it's not going to influence the child's life, but it's going to influence the parents. I mean, it terrifies parents to have their child lose consciousness and shake, right? So this again, though, despite that, this is watchful waiting and a lot of reassurance and treating the fever. Now, this, on the other hand, anyone know the name for seizures when they don't stop? This is a neurologic emergency. Yes, exactly right. So I see status epilepticus in the chat, and that is what we're going to talk about here. So a seizure that is going on for more than 5 minutes is incredibly dangerous and needs immediate attention. Oh, go ahead. Sorry. I'm clicking around my screen and having some aberrant clicks here. Okay, so things about this. Number one, the longer the seizure goes on, the more difficult it becomes to treat. So someone who has you notice that most of the seizure examples I gave you, it was like a 30-second event, a 2-minute event. If it's going on for 5 minutes generalized, that is very concerning. If there's no treatment given to someone in status, about 1 out of 5 patients will pass away from the status because your brain is not oxygenating correctly. This is also a very metabolically intense thing when you have all of this shaking. And so there can be secondary hypoxia from it. So someone comes in status, like all patients in the emergency room, first you check their airway, their breathing, their circulation. You always check glucose because hypoglycemia can cause seizures in vulnerable patients. You get them on oxygen and you get them treated. Almost all of the agents that we use, so this is the first time we're talking about treatment in this, but almost all of the agents that we use are GABAergic. And there's some interesting pathophys here. I like understanding why. The reason it gets harder to treat the longer it goes on is all of these medicines work on our GABA system, okay? And the longer you seize, your GABA receptors on your neurons actually get internalized. So then the medicines work less well the longer you've been seizing. So the goal really is you want to have this person, if they don't respond to those first line benzos, then they get loaded with something IV, and then they get put on a continuous infusion as quickly as possible. So we'll essentially induce a coma with a benzodiazepine drip or propofol or pentobarbital, depending on what's available, in order to just kind of shut their brain down so that it's not seizing. It's much better for them to be unconscious chemically than for them to be continuing to seize. Any questions about status? This is one of those things you recognize it. One of the things that can be often awful about status epilepticus is the shaking often burns out. Like people come in and they shake for a bit and then they can just be unconscious. And once they're just unconscious, you don't know whether they're just kind of knocked out from the medicines in the postictal state or whether they're still seizing. So if you have access to EEG, that's a time when it can be very, very useful to see what their brainwaves are doing. So now we're going to return as we start to get towards our last points of this, towards our seizure clinical approach and workup. So we already talked about getting history and characterizing the event. Talking about investigate, I was going to ask you to think about it, but I already put it on the slide, so I know you can all read. In addition to getting routine labs, the 2 main things we think about are imaging and EEG. And then we'll talk a little bit more about treatment. As we think about treatment, not every seizure needs to be treated if it's very provoked. Sometimes someone is put on a new medicine, they seize. I had a friend that this happened to in medical school. They're taken off the medicine, they never have a seizure again. They don't need treatment, but they need to not be on the medicine that made them seize, right? So when you consider whether it's provoked, you consider the risk of recurrence. Any first-time seizure has about a 50% chance of happening again. So, or 40 to 50%. So if it's not provoked, if there's things about it that make you worry, like they have an abnormal imaging, then you might be more likely to treat them. If it was clearly provoked and everything else is very normal, you're going to be less likely to treat them. So let's talk a little bit about MRI. So I think many of you know MRI versus CT. MRI is more like I think of it more like like the high quality, very detailed picture of the brain. And I think of the CT more like kind of like an old black and white TV. The thing about a CT is it's what we're going to use in the ER, right? Because does anyone know the difference in how much time it takes to get a CT versus an MRI? So CTs can be done in a matter of a minute or two, maybe 5, and MRIs can often take 30 to 45 minutes. So if someone is seizing, you're not going to put them in an MRI scanner where you can't stabilize them. There's also just practicalities to this, in addition to the fact that a CT is a more widely available, more cost-effective thing. So MRIs are great, and often CTs are what is used in practice. I happen to practice in a setting where we MRI everything. And I've also been in hospitals and rotated through hospitals where they CT everything. What you're looking for when you do an MRI of a patient is there a lesion, especially if they had a focal onset seizure? What is causing that irritation that's making those neurons fire in synchrony? The picture I gave you is a coronal section of a brain. And many of you might recognize, we're looking here at the medial temporal lobe. So this is the normal side over here on the right. Recall that right is left and left is right with how we look at radiology. And here you can see it's labeled as smaller and brighter. So this hippocampus is smaller, and you can see that there's some bright signal on the MRI. So this is what something called mesial temporal sclerosis looks like. Mesial temporal sclerosis is one of the, it's a kind of like a idiopathic scarring of the hippocampus. And when that happens, the neurons regenerate in a way that often generates epilepsy and generates seizures. Other things we find on MRIs in up to a third of cases, there'll be some kind of lesion. It could be an old stroke that may have even been asymptomatic. There can be a tumor growing, and it's not uncommon for new brain tumors to present with seizure. Or there can be cortical malformations. Sometimes, like I mentioned, a little part of the brain just doesn't migrate correctly when we're developing in utero, and it isn't found out until there's a seizure. Infections and neurocysticercosis are a very common cause of seizure that is definitely more prevalent in some parts of the world. We see it a lot in our patients in the US who are originally from Mexico. There's a lot more neurocysticercosis endemic there, and it's also endemic certainly in parts of India. And then EEG. So have any of you, give me a thumbs up, have any of you seen an EEG? Cool. So an EEG, okay, we got go. Okay, a couple of you have seen EEGs. Oh, I liked that. So awesome. So for those of you who for whom this is review, the patient is hooked up to many electrodes. So we're looking at the surface electrical activity through the scalp, what we can get from. So we're really only getting the surface of some of the gyri, right? And a normal EEG is what I'm showing you on the top of this slide. There's a lot of electrical activity. There's nothing that looks super sharp or super rhythmic. On the bottom, I'm actually showing you, this is the 3 Hertz spike and wave pattern that you see in absence epilepsy, where it's generalized. So you see it in all of the leads throughout the cortex. And you see that same pattern where there's a little bit of a start and a buildup. Seizures tend to be very spiky and very sharp. We often refer to patients as having sharps on the EEG when they have seizures. And again, there's kind of a beginning, there's the seizure, and there's the end. And then there's often some suppression with less activity than the normal after a seizure. So these can be used. I showed you an example of a generalized seizure, but you can also sometimes see seizures on this that are focal in onset, and you can actually see where they start. And we sometimes do things like surgery to take out the seizure nidus. And so it can actually show you where to go to stop the origin of the seizures. And of course, this is also very useful in distinguishing seizures from mimics. EEG is most helpful the sooner you do it to the seizure. So if someone is admitted and there is EEG inpatient, it's great to do it as soon as possible to see if you capture some sharps or some spikes. One of the issues, though, is EEG can be absolutely normal between episodes. So someone can come in with a shaking episode, you put them on the EEG and it's totally normal. They still have a 50% chance that, or if they had epilepsy, there's still a 50% chance it's normal in between. So EEG is a useful tool, but often if we have a high suspicion for epilepsy, we repeat it quite a few times. So inpatient, sometimes people are hooked up to continuous EEG. Outpatient will do spot EEGs where they come in and we just look at their brainwaves for 20 minutes and hopefully capture some episodes. All right, I have 2 more slides. If you're all still with me, then you're doing well. One actually, it might be 3. I may have lied, but don't worry, we will wrap up right on time here. So treatment and prognosis of seizures and epilepsy. This is really treatment and prognosis of people with epilepsy. So we're talking now of people who have repeated seizures. With epilepsy, we medicate epilepsy. We do not want them to continue to have seizures because seizures have that risk of status. Status has that risk of death. So one medication will cause remission and control seizures in more than half of patients. That's actually this box on the right. And you get another 10 to 20% when you do multiple medications and try some different ones and sometimes do combination therapy. So medicines fix epilepsy, fix it, control it very well in up to 70% of patients. There is about a third of patients that have drug-resistant epilepsy, which means they still have some seizures despite being on at least 2 medicines. I listed a couple of the common medications here. For focal seizures, carbamazepine is only good for focal onset. Lamotrigine, which is Lamictal, we often use outpatient because it's a really slow titration. So you can't use that in the moment, but you can build it up over time. And then levetiracetam, brand name is Keppra, is a really common seizure medicine. We talked about ethosuximab for absence, and valproate is often used. We still use phenytoin a lot. It's a very effective medicine for inpatient when you need to like stop a generalized seizure. Phenobarbital has really fallen out of practice in the US, but my understanding is it is still used a good bit in India, just due to different availability. And it's a very effective and it's a very available and cost-effective medicine. And it can be used really for all seizure types. It has more side effects and more potential sedation and some other things to it. And then there's always the new and the exciting. So for these patients, for that third of patients with repetitive seizures, and seizures are if you are worried that you might, as was described very beautifully at the beginning of this, right? That your brain might just collapse on you at any time. You might lose consciousness. You might shake in public. It can really, really change people's lives and really change the way that they approach things. And there can be so much anxiety and so much just issue around having epilepsy that we certainly want to help people go back to living normal lives as much as possible. So in patients that do not respond to medicine, they are sometimes candidates this is just a variety of the procedures, either surgeries or procedures that we do in refractory patients. So in patients in whom the seizures are originating from the temporal lobe, they'll actually go in, and our neurosurgery colleagues in close partnership with us will do a small resection of the part of the brain that's most likely causing it. It can also be a laser ablation. So that means it's not actually an open surgery. They can actually use lasers without opening the skull to ablate that part of the brain. And then there's a variety of stimulators. Vagus nerve stimulators are interesting. We don't totally understand the pathophysiology of how they reduce seizures, but vagus nerve stimulation is used for so many different things, and seizures are one of them. Deep brain stimulation, much like we do for Parkinson's, can also be used towards seizures. So you can have resection, you can have ablation, and you can have different types of stimulation to help calm seizures, to help disrupt that hypersynchronicity that causes these electrical storms. We also know, especially in Lennox-Gastaut and some of the specific pediatric epilepsy syndromes, the ketogenic diet, it is a very strict diet, can be helpful. And then we're getting better at really figuring out some of the genetic underpinnings of specific epilepsy syndromes and pairing them to medicines. Specific to, I practice in the United States, and getting the privilege of, speaking with all of you in India. A couple of things that are specific to India that I can share with you are you have actually a fifth of the world's epilepsy cases. So there's a large epilepsy burden in India. And you can compare the 12 billion, we have about 3.4 million in the US. And you have such a just beautifully wide and diverse country with a lot of rural areas. And any place it's true in the US, it's true in India. Rural areas mean less access and more cost of care. Stigma is alive and well in many parts of the world. around seizures. So there can be stigma around ability to marry, to have education, employment. Like there's a lot of things that really need to be addressed with people with epilepsy to support them. The other thing that's a little more specific to India that I mentioned, we see a lot in our patients also from parts of South America, is neurocysticercosis. So it's responsible for about 30% of epilepsy in the parts of India that have endemic neurocysticercosis. And we see that in the parts of the US and again in Mexico, where we have a lot of people in the US who are originally from Mexico, that have a higher risk of neurocysticercosis. So you get these little lesions in the brain, they cause inflammation that causes seizures. And with that, these are some take-home points for you to read to yourselves. And that is all I have for you today, but I'm certainly happy to take any questions. I know this is a whirlwind tour of seizures and epilepsy, but I do hope that it was a good review. Thank you.
That was an amazing session, ma'am. Probably we have a few questions that we've received via the Google Forms, so I'll be asking them.
Sure.
The first one goes, in patients presenting with a first unprovoked seizure, what clinical or EEG feature most strongly predicts recurrence and influences your decision to start the medication?
Oh, that's a great question. Oh, so we're assuming that we feel convinced that it is a seizure based on the description we have. That's the first thing I always ask when it's a first event is this really a seizure? But let's assume it's a pretty compelling description for seizure. There's not one thing, because everything kind of, you take all of these different items, right, and they each make your suspicion go up or down a bit. But having an abnormal EEG is probably the most specific, right? Like if we actually see that there are sharps and irritability in the brain, that's going to greatly increase my suspicion. The thing that comes right after that is an abnormality on the brain MRI that would put them at high risk for seizure, like a focal cortical dysplasia, that part of the brain that didn't develop quite right, or any kind of other scarring or inflammation, seeing neurocysticercosis in the brain with a compelling story. So if they either have if they have a compelling event with an abnormal EEG or a compelling event with an abnormal imaging that supports the compelling event, like let's say it started in their left arm and I see something in their right motor cortex, I'm absolutely going to recommend starting medicine, even though it's one event. It's a great question.
Yeah. The second one goes, do genetics have any effect on seizures?
Oh, that's a really good question. It's a bit specific to what kind of seizures we're talking about. So in general, there's not a large genetic footprint to seizures just because most seizures are focal in onset, about 2/3 during adulthood from acquired brain lesions. So clearly someone, if the seizures from having a stroke, from neurocysticercosis, from something that has caused an irritable foci in the brain, no genetic footprint, right? But that being said, all of the childhood epilepsy syndromes all have more of a genetic footprint. Absence seizure does, Lennox-Gastaut does, a bunch of the childhood ones do. So it depends a bit on that. But if you're someone who's going like, I have a parent with epilepsy, they developed it in their 50s or 60s, the chance of that being genetic is much lower. Yeah, great question.
Another question, it goes like, when is it considered safe to stop the anti-epileptic drug course? Can someone who is consistent with their medication be fully cured?
That is a great question. So yes, it does happen. And we definitely see patients that will have a cluster of seizures. They'll be very well controlled on medicine, and they'll ask that question. Whether to stop it depends on a couple things. One, if we're stopping it. So seizures preclude driving, right? Like if you are at risk for loss of consciousness, then there are laws that, at least in the US, I have to report that patient to our Department of Motor Vehicles. There are similar laws in India, I believe. So if I'm stopping an anti-epileptic, the patient has to be willing to not drive while we stop it. So there's a lot of social complications to stopping it. And it depends a lot on whether they're willing to do that whether the medicine is disrupting them. Like if they're having a side effect, I'm more likely to go on that adventure of stopping it with them. And also how disruptive their seizures were. Are these generalized seizures where they were going into status, or was this like their arm shook a little bit and we feel comfortable? Like I stopped an anti-epileptic recently on a patient who had sensory only seizures. They had a meningioma, it was resected, it was in their sensory cortex, and their leg would kind of tingle and it would creep up their leg. It was very clearly a seizure. Had no problem trying that patient off of medicine. Um, Typically, my rule of thumb is if they've been controlled for about 2 years, I'm willing to have the conversation.
Yes, ma'am. Just as you mentioned, we here in India do have rules, uh, like you mentioned about the motor stuff. Probably
Mm-hmm.
when we talk about the driving, yes, it is kind of prohibited for, I think, probably a few months whenever
Mm-hmm.
they're just on their anti-epileptic drugs to just make sure probably they're not harming themselves and not the others as well. So yeah, that works here in India as well.
Yeah.
So now, probably the panel is open to the attendees. We can have at least a few questions, if that's okay with you, ma'am. Since we're running out of
Yeah,
time, we
no
can just
problem. I
have a
know
few
we're
questions.
sure, no problem.
Thank you so much, ma'am.
Good evening, ma'am.
Go ahead. Hi.
My question is AI or machine learning being used in seizure prediction or diagnosis? If yes, then
Mhm.
how?
Yes. So there are many examples of how we're using AI and machine learning. And I probably won't be able to accurately represent all of them. But one of the most interesting ones that I'll give you full disclosure was developed by one of my colleagues at Stanford. So I've heard an exceptional amount about it just because it's local to us, is a machine called Cerebell that uses AI. So rather than hooking the patient up and having an EEG tech who understands how to glue all of the electrodes onto their brain in just the right configuration, it's just a cap that they wear. And instead of having someone who has to go in and read the brain waves, there's an AI that detects based on it takes the brain waves and it converts them to sound. And the AI detects whether the sound is consistent with seizure. It's really interesting when you listen to it. Like normal brain sounds like status, and seizures sound like a scream. And the interesting thing about that technology is it really increases access to EEG in places that don't have epileptologists, that don't have neurology. They can still put the cap on and it will tell them whether it's likely a seizure or likely not. So, and it's all powered through a lot of AI and machine learning. So one example, and there are many others. Yeah,
Okay, ma'am, thank you.
you're very welcome. And I see a note in the chat that asks about the major challenges faced in diagnosing and treating seizures. There are many. I think access is one of the biggest ones. Another um, is getting that really good history. Like it's not uncommon for people with, for example, the psychiatric non-epileptic events. I mentioned it can take 7 years for someone to really take the time to do the very careful history and the testing to figure out that this isn't epilepsy at all. We all are going to be working. I am working, and you will all be working in healthcare systems where there's never quite enough resources and there's never quite enough time. And that I think it's not unique to seizures, but I think it's a huge barrier, and it's a barrier to those and many other neurologic things.
Hi, Dr. Rebecca. I have a question for you. Since we discussed that sleep deficiency or someone who sleeps less is more prone to having or developing seizures, is it possible that someone who's perfectly fine can or who has had previous episodes of seizures, just one at a time, can they
Mm-hmm.
seizure in their sleep? Can they seizure during their sleep? Because I've had a very close family member of mine from my extended family. She
Mm-hmm.
just had a seizure. She was sleeping. Her mother was trying
Mm-hmm.
to wake her up, and she
Mm-hmm.
could not wake up. And when she woke
Mm-hmm.
up, she described muscle soreness, which she typically
Mm-hmm.
had
Yeah.
after an episode of seizure. So, is it possible to seizure in sleep?
Absolutely. Yes. Seizures can absolutely happen in sleep. Sleep
Okay.
deprivation is one of the things that, can make seizures more likely. And sometimes outpatient, when we're doing an EEG, will actually make the patient stay up to make it more likely to see something. But that being said, that's just because that's one thing that lowers the seizure threshold. Someone with epilepsy can seize when they're awake or asleep, regardless of how much they've slept. And
Oh,
that nocturnal seizures, especially if there's incontinence at nighttime, tumbling at nighttime, muscle soreness, those can all be signs of a seizure. It's a great
right.
question.
Okay. That being said, can all of these events further lead to effects like side effects like forgetfulness, general tremors in the hands? Because even after being on medication, the girl, she has tremors in her hands, and
Mhm.
she forgets things like just 5 minutes after doing something, she's like, what did I say? What did I do? So is it like a further consequence? Is it a sequelae of that?
It can be. So seizures themselves can definitely, especially if there have been many over time, can have cognitive consequences. It can also be a side effect of the medicine for the seizure, right? So many of the medicines, all of the medicines for seizures are causing more inhibition of the brain, right? They're neurodepressants. And so
Mhm.
more forgetfulness and sleepiness can also be a side effect of the medicine. So you have to differentiate those two.
Right.
Seizures don't usually cause tremulousness themselves in between events.
Hmm.
EEG can definitely help figure out whether it's the seizure, but if it's both hands shaking a little bit, that's probably unrelated, or it's part of, if there's a bigger syndrome causing both the seizures and the shakiness, that's the other way you could put those together.
Right. Last question. I'm going to make it quick. Can nutritional deficiencies add to the severity of the seizures, or can they precipitate seizures?
Some can, yes, for sure.
All
It
right.
depends a bit on the specifics, the devil's in the details of that one, but yes, that can happen.
All right. Thank you so much.
You're welcome.
Since we're running out of time, let's just end this with the last question. Ma'am, if you had to give just one piece of advice to medical students who aspire to be neurologists, what would it be?
Oh, go for it. I mean, that's, I
But that's literally
guess
the
it's,
key. Just going for
mhm,
it.
mhm. Absolutely. It's a wonderful field. I mean, I will also say that as medical students often lose a lot of sleep over what specialty to go in, and you can find something that you love in any specialty. I chose neurology very much at the last minute, and I absolutely adore my career because I kind of liked everything that I did. And I think that we often think that these choices are almost more important than they are because there's so many choices after you choose your specialty, what you do within it, how you decide to structure your practice, whether you're in the hospital or outside. Like there's just so many choices. But I will say neurology, for such a long time, we couldn't treat the brain. And now we have just this increasing candyland of tools that we can use to make such a meaningful difference. And like, if your brain isn't working, to me, the reason I finally chose neuro is kidneys very important, heart very important, can't live without them. But like, if your brain isn't working, even if everything else is, like, you've lost so much of your life and who you are that like, it just feels like such an amazing thing to be able to help people optimize and protect. It's a really wonderful thing I highly recommend a career in neurology if it's available to you. So
So rightly said, ma'am. Um, if it's possible, I would really like all the attendees to please uncam themselves so that we can have a picture. Yeah. Thank you so much. Thank you so much, ma'am. That was a truly insightful and engaging session. And so sorry we're just 13 minutes over time.
no problem.
But the epilepsy in India part, that was so personalized and it was just so amazing. The way you simplified the concepts and the case based approach was the best. On behalf of the entire team of SGRD Sign, I would just like to express a heartfelt thank you that you took your time out and you shared your valuable knowledge with all of us. It was truly an honor and a privilege to host you. Thank you so much, ma'am. Thank you so much.
No, thank you so much for having me. It's my pleasure. Hope you have a wonderful rest of your days.
Thank you so much, ma'am. Bye bye. See you.